Great. So good evening, everyone, and welcome to this evening's School of Hepatology virtual webinar. Our topic this evening is Managing Frailty and Cirrhosis, the MDT approach. My name's Dr. Louisa Vine, and I'm the Basel Education Lead, and I'll be one of your chairs for this evening. And my co-chair is Dr. Howley, the Basel Trainee Rep. I'd like to thank our sponsors. So it's AstraZeneca, Advanced Pharma, and Dr. Falk. The sponsors have no influence or input into the programme, agenda, or content of the meeting. So I'd like to introduce our speakers for the evening, Professor Matthew Armstrong and Jenny Towie. So Professor Matthew Armstrong has been a consultant hepatologist at the Liver Transplant Unit in Birmingham since 2017. He is the Centre Director for Liver Transplant Services. His PhD and more than 150 publications are based on developments in MARSLD, frailty, exercise and liver transplantation. Jenny Towie is a specialist hepatology and liver transplant dietitian, also working in the liver unit in Birmingham. She has previously been an HEE/NIHR award holder for a pre-doctoral clinical academic fellowship. Her interests include nutritional assessment and management of encephalopathy. She's actively involved in research and is passionate about standardising nutritional assessment and management for all those with end-stage liver disease. If you have any questions this evening, then please do put them in the question and answer box, and we will answer these at the end of the talk. So I think that's everything that I needed to say. So without any further ado, I'm going to hand over to Professor Armstrong and Jenny for the talk. Thank you very much indeed for your time.
Good. So thank you very much for the invite. And as Louise has already said, we're going to be talking about how you manage a frail patient in cirrhosis, but the MDT approach. And I must say that Jenny in clinic is a lot more important than me, because I'm certainly no intervention, but she certainly is. So what we wanted to go through is physical frailty, what it actually means, the impact of physical frailty, how you assess it from a nutritional point of view and from a physical frailty point of view, what the concept of whole body prehabilitation is, i.e. we're not just going to focus on nutrition and exercise, but as clinicians, what else we can be doing for these patients. Embedded in this talk, we're going to discuss a couple of challenging cases and how myself, and in particular Jenny, would manage this with the nuances that you can't really get off the internet or from textbooks. And then very much pressing the button of that this is an individualized, tailored approach for each individual and isn't a one shoe fits all approach. So what is physical frailty? It's basically a broad term that encompasses sarcopenia, whose definition changes every year depending on what textbook you read, but in general, it's a decrease in muscle mass, but most recent definitions also recommend that it's a decrease in strength and function. But overall, it's a decrease in performance status and functional decline. It's associated with aging and also malnutrition. It kind of comes in keeping with how severe your liver disease. So it goes back and forth, i.e. the worse your liver disease, the more likely you are to be sarcopenic, and the more sarcopenic you are, the more likely you are to decompensate from your liver disease. As you can see, it's extremely common. For some reason, it's more common in males, which we might come on to later. But overall, it increases your risk of mortality, both pre and post-transplant, increases your hospital duration, your susceptibility to infections, and overall gives you a poor quality of life with more surgical complications. And that's whether you're having a TIPS, a GI bleed, an ablation. Overall, the complications as such are more complicated if you're frail. So this is what it basically means. This terminology has been used for a long time now, over 20 years, but you basically have a decreased physiological reserve and an increasing vulnerability for any health stress. So if you've got a low reserve, you will sadly, with an acute event, and in our case, it's probably a GI bleed, episode of sepsis, pneumonia, a complication of a TIPS or surgery, you drop into the danger zone, which I call the zone of adverse outcomes. And despite experts like Jenny, anaesthetists, etc., trying to get you out of that red zone is very hard. And even if you've got high physiological reserve and you're physically fit, you will certainly drop off in your physiological reserve of the acute insult, but you then can improve without being in the danger zone thereafter. I think one thing I found staggering when I started researching frailty about 10 years ago is that a patient with cirrhosis may have a chronological age of about 57, but their biological age and their physical age is more of an 85-year-old in the community. And we call this the perfect storm, and Jenny will allude to this when she's talking about some of her interventions, but cirrhotic patients have inadequate intake because they've got altered taste, alcohol can decrease your appetite, the ascites limits your intake, they have early satiety, and then also hepatic encephalopathy means they forget to eat. You then add this on to reduce physical activity, immobility, depression, behavioral problems, fatigue, and myalgia, together with the metabolic complications of cirrhosis. So the best way to look at it, a cirrhosis patient is pretty much doing a London marathon every day. They're completely breaking down their protein. They're struggling to make protein. And at the same time, they have very poor glycogen storage, as if they've reached 21 miles of a 26-mile marathon. You then add on malabsorption due to portal hypertension and pancreatic insufficiency. And all in all, it's the perfect storm for making that patient frail. So to give you a case example, this is George. He's a 59-year-old lorry driver, happily married, but he's got the full plethora of metabolic syndrome. A BMI of 45, his diabetes is challenging to control, just on metformin. He's on a statin and he's a smoker, but he also has chronic iron deficiency, which may be relevant later. He has right knee osteoarthritis, of which he's on quite a lot of morphine. And also he's on mirtazapine for depression at the top dose of 45 milligrams. He's got a diagnosis of mastoid cirrhosis, which is compensated, but his FibroScan implies that he's got a degree of portal hypertension as he's over the Baveno score. And this was proved by having an endoscopy. And as you can see, his varices are quite chunky, which we would say grade 2, and therefore he's placed on carvedilol. Sadly for George, on his routine ultrasound screening, it picked up an approximate 2 centimetre mass, which is highlighted on the CT scan, the cross-sectional imaging. And then the questions are, because it's 2 centimetres, is he fit enough for a transplant referral? Is he too high risk? Should we be going for an ablation SABR instead? And even if we are going for intervention directly of a cancer, how can we optimize this guy moving forward? So over to you, Jenny.
Thanks, Matt. And that was a really perfect set the scene of the challenges that we have with these patients. So in terms of intervention, it's important that we're looking holistically at these patients and not just one or two small things. So it's important that first we're looking at what they're eating and taking a really good diet history, and trying to get a good snapshot of the types of foods these patients are eating and the pattern of eating as well, because as you've all heard, that all of those areas are really important. So George reports that he's eating large portions, and when he snacks, he's eating a lot of carbohydrates, and a lot of his meals and food choices have quite a high fat content. And even those in isolation in the context of all the metabolic risks that George already has, if you continue to eat this way, it's likely to further worsen those comorbidities. We're going to have ongoing challenges with diabetes, and ongoing risk with increasing weight. As you've heard, these patients are often what we call sarcopenic, so muscle mass can be challenging to maintain. That can impact function, that can impact symptoms of liver disease. So it's really important that we're taking a detailed assessment of muscle and grip strength. It's well recognised in the guidelines that these patients ideally should be having imaging to assess their sarcopenia, but as we know, that can be challenging to access, it can be expensive, and it's not accessible to all patients. So a really good bedside measure of muscle mass is looking at their mid-arm muscle circumference. So this is used as a combination of measuring mid-arm circumference and tricep skin folds, so looking at their upper body fat mass. And this can give you a really good idea of their proportion of skeletal muscle mass. It's important that this is interpreted within sex-specific centile ranges. And for George, his muscle mass is showing within the 50th centile. Just to put that into context, that's saying that his muscle mass is around 50% of the average of the general population. And if you then relate that back to his current BMI and his weight, that muscle mass is significantly low. So whilst it might sound reasonable, put into context with George, his muscle mass is incredibly low. And this is also relates back to his hand grip strength, which was measured through hand grip dynamometers. And his average has come out of 27 kilograms. And this is coming out at around 60% of the sex-specific norm for George as well. So not only is he eating large portions, high carbohydrate and high fat foods, his muscle mass is low and his hand grip strength is really low as well. So he's demonstrating evidence of protein energy malnutrition, he's sarcopenic, and he's likely to have an element of frailty as well. So next slide, Matt. And again, just to quickly touch upon body mass index, generally it isn't overly reliable in the context of fluid retention, as we know, but there is really good evidence that when we're estimating dry weight with these patients, BMI can predict mortality, and that's at either end of the scale. So it's not only important to be looking at muscle mass and function, we want to make sure that our patients are managing their weight appropriately as well. Next slide, Matt.
Yeah, so from the same study that we did with BLTG about 6 years ago now, we wanted to really look in a large cohort of patients who are post-transplant, but what their metabolic syndrome looked like at baseline. And as you can see, once you reach the threshold of having 2 or more metabolic risk factors, your post-transplant survival significantly drops off. You pretty much double your length of stay on ITU. Your chances of ending up on renal support is 1 in 4. So we're talking someone who's going into transplant with a BMI of 31 dry, together with well-controlled type 2 diabetes, is still got a 1 in 4 chance of ending up on renal support post. I mean, we're always asked, how do you assess physical frailty? I would try and keep this as simple as possible. Ideally, use the liver frailty index, or if you want a snapshot from the end of the bed or in clinic, you can use something called the clinical frailty scale, which is an eyeball measure with a sheet in front of you picking a score of 1 to 10. But then there are the nuances as well, where because physical frailty captures sarcopenia, physical function, disability, and functional capacity, there are elements within all of them that you can use different tools. So functional capacity, probably the most reasonable one, is to use the 6-minute walk test in a clinical setting, but you do need a 30-meter stretch in order to do so. Physical ability, which I think is really important, especially when referring a patient for transplant. I mean, how much activities of daily living and instrumental activities can they actually do? We're not quite there with muscle ultrasound yet. That needs a lot more validation, but certainly moving forward in the future, an ITU could be a tool that we can use. And as Jenny's already alluded to, using the skeletal muscle index on CT is useful, but it doesn't really give you an indication on physical function like hand grip strength does for the upper limb and chair stands for the lower limb. And this is what we would recommend, a physical frailty assessment using the liver frailty index. So in George's case, his liver frailty index is 4.2, which places him at the pre-frail cascade, but he falls within the 72th percentile. But interestingly, his Darcy index implies that his aerobic capacity, i.e. his exercise capacity, is pretty woeful. It scores 17 points overall, and we know that pretty much when you're reaching 16 points, your predictive of death massively improves, but I mean, it deteriorates. But a MET score of 4.8 really starts to get our anaesthetist very twitchy. The Darcy has been shown in other types of surgery, not transplant surgery, but in other types, to pretty much correlate with the cardiopulmonary exercise test, whether it be it on a bike or a treadmill. And overall, these two tests take 5 to 10 minutes in outpatients. They're not expensive, they're reproducible, and they really should guide the type and the intensity of exercise that you want to start on these patients moving forward. So Felicity Williams did a lot of work with this in over 300 patients, prospectively collected their liver frailty index whilst on the transplant waiting list and the Duke activity index via the questionnaire. In general, the green lines, as you can see, are those patients with a low frailty index, i.e. that means they're robust, and the red line is those that are more frail. And as you can see, their survival probability over time is much worse and drops off rapidly within the first 100 days if you're frail. Even more so with the Duke activity index. Once your score gets around 16, like I was saying with regards to George, you can see from that red line, again, your survival at 1 year is almost down to 75%, which is woeful really when you compare it to someone who's more robust, like the green line, and outcomes that we would expect at around 97, 98%. The predictors of frail are generally female, but Jenny will come on to the fact that a lot of females have low muscle mass but good function, low sodium, which is pretty much a marker of terrible liver disease, and then age and cephalopathy and BMI all predict a poor Duke activity index for obvious reasons. So this terminology of prehabilitation, so how do we take either the frailest of patients and enhance their functional capacity to withstand a stressful insult like a bleed or a transplant in itself and bring them out of that red zone? But also, I'm a true believer that if someone's winning bronze at the Olympics with the right expertise, you might be able to escalate them to a silver or a gold. So just because they're quite physically robust does not mean they can get marginal gains with the help of dietitians and physiotherapists. So as I said, trying to move the frail so they improve, so they can actually get out of the red zone with an insult. But also, even if you're very robust, you may have a GI bleed, drop off, slightly improve, then a pneumonia post GI bleed, drop off, but you're still able to get out of the danger red zone, which pretty much results in death. And when I say prehabilitation, I really want you to think about whole person optimization. So if we go back to George's case and we look at how we can optimize his cognition, depression, polypharmacy, alcohol, substance abuse, medical health symptoms, encourage other social supports. First of all, because of his depression, has he had talking therapy? Has he been linked in with CBT? Is the choice of antidepressants accurate for him? I mean, mirtazapine, we know increases appetite and leads to weight gain, which might not be ideal for someone who's got sarcopenic obesity. The MST in itself might help him deteriorate into encephalopathy and make him constipated. Smoking, we know, breaks down protein and inhibits protein synthesis, which is exactly not what you want when we're trying to get someone fit enough. And also giving him clear goals of what his targets are, his achievements. But at the same time, asking our local clinicians if he can have an iron infusion to optimize his anemia, giving him vitamin D because he's vitamin D deficient, which may be contributing to his fatigue. And also, as I said, involving his family and his social support network in this plan. Over to you, Jenny.
Thanks. So nutrition really is key with these patient groups, and it shouldn't just be seen as a additional supportive intervention. It really is something that can help manage these patients. So just to keep it really simple, there are some really good guidelines. So here the EASL guidelines have recommendations for energy and protein requirements dependent on whether the patient is compensating or decompensating cirrhosis. Again, it needs to be tailored to the individual. So it's important to look at, have they lost any weight, what your target is, are you trying to achieve weight gain? That will help you gauge their energy requirements. Protein will be dependent on your target based on if they're carrying additional fluid, if you're looking at gaining muscle, so muscle synthesis. So if we're looking at George, he's overweight. Ideally, we'd like to lose some weight. We'd be aiming for a slightly lower energy requirement for him, but we'd be trying to really optimize that protein requirement to support muscle synthesis. Traditional sort of advice we'd be giving was that regular eating pattern. So we do want George to still eat regularly, but we need to be thinking about what he is actually taking in. So his food history reports he's got a high carbohydrate, high fat content in his diet. So we'd want to be swapping his snacks out, removing the carbohydrate from those, looking at lean protein sources. So that could be things like Greek yogurts, glasses of milk. You could be looking at cold meats, for example. You might need support of nutritional supplements in this context as well. So we'd be looking at low calorie, low fat, high protein supplements, and there are quite a lot of suitable products on the market now. We'd still want to make sure that he has carbohydrate within his main meals, but again, looking at the carbohydrate content and where he's getting those from, and keeping fat to a minimum. And just to give you some examples of the nutritional supplements that are available, it is important just to get to know what you are able to prescribe within your area and in your hospital setting, and also have a look at the nutritional values. Often we see patients put on the sort of cheaper options. So that might be things like your full calorie supplements, which give you a slightly lower protein content. Whereas really, if you're looking at long-term cost effectiveness, it's going to benefit your patient more to be on that slightly more expensive supplement, but that isn't going to burden them with high calorie, high fat, high carbohydrate, but it's giving them that really good lean quality protein source. So I think for George, we'd be looking at adjusting his snacks, reducing his portion sizes at his meal times, but ensuring he's getting good quality carbohydrate and protein with his meals, and supplementing some of those snacks and pre-bedtime with a good quality protein supplement. Next slide. And just to touch on the timing of nutrition, so obviously as part of this talk, when we're looking at managing frailty, we're looking at the nutrition timing alongside exercise as well. So it's important that you're encouraging your patients to move more, whether that's increasing their general activity or exercise, but it's looking at the timing of the nutrition. So we should be ensuring that these patients are exercising fasted. We want to make sure they're getting a good carbohydrate before they exercise. But it's making sure that that carbohydrate is going to be slow releasing. So you want something that's just going to, quick release, and to give them a really quick hit of carbohydrate. So that might be things like some toast, some cereal, it might be a sandwich, or it might be a meal that they're going to have. And then after exercise, they want to be making sure within the sort of first 30 to 60 minutes after after exercising, they're having a good mixture of protein and carbohydrates. So that's refueling, giving them some quick available energy again, but giving them that protein to help with that recovery after they've moved or after they've exercised. Next slide.
Yes, I get asked a lot about diabetes medications in these kind of patients. So the first thing to say is a rough guide in anyone who's kind of on the borderline of decompensation or is decompensated, completely avoid glycoside, mainly because of the hypoglycemic effect. Dapagliflozin would also run the risk of giving this gentleman ketoacidosis. So we always recommend dapagliflozin is stopped before any procedure or operation. What the safe options are, though, linagliptin is a safe option for people with renal failure and liver failure, and you don't really need to be testing any blood sugars for hypos. But really, if a patient has a HbA1c in the realms of 79, is on the cusp of decompensation or is decompensated, insulin is still by far the safest option, especially if we're considering altering their nutrition and in a patient who may need an overnight NG feed. Again, insulin by far is the most safest. However, I have no doubt all of you have heard about Mounjaro, Wegovy, Ozempic. They spend most of the time in the Daily Mail or on Kim Kardashian's website. What I would say about these drugs is we are starting to use them in compensated child's A cirrhosis, and very rarely we use them in decompensation, but you absolutely need a Jenny alongside you in clinic, because if the patient's not meeting their protein requirements and maintaining their muscle mass, these drugs are dangerous. And what the trials do show is that you can lose lean muscle mass as well as adipose with them. So it's got to be done in the right setting. But there's no doubt they are here to stay, but it's how we manage the muscle alongside them. Back to you, Jenny.
So just as a bit of contrast, we're going to talk through Lisa, who's a 42-year-old female. She was as a retired PE teacher, and she lives with her partner. Her comorbidities, she's got a history of a high alcohol intake, so an averaging 110 units per week. She's on propranolol for anxiety. She's got psoriasis, and she's previously been found to have pancreatitis. She's a smoker with a 20-pack year history, and she was reviewed in an outpatient clinic. Next slide. So the symptoms she's reporting in this clinic appointment are diarrhea, dizziness, and weight loss. Currently requiring 8 litres of paracentesis every fortnight. She's already been previously diagnosed from her referring centre with encephalopathy, which has required 1 hospital admission. And she's currently taking lactulose and QDS to try and manage that. She's jaundiced with a bilirubin of 110. She's got a higher INR and she's anemic, and she's currently presenting as child's Pew C10. Next slide. So on further discussion with Lisa, she's reporting that she's been engaging recovery and has been abstinent for the last 3 months. She was seen in our high intensity alcohol clinic, so she's had access to a nurse specialist, addiction psychiatrist, a hepatologist, and also a specialist dietitian. And after that assessment, the discussion was, is there any surgical improvements she needs to make, or could she be considered for a liver transplant presently as she is? So again, similar to George, we want to make sure we're doing a thorough nutrition assessment with this patient, but the difference for Lisa is that she's presenting as decompensated, and primarily she's still requiring that high volume paracentesis regularly. So it's important that when we're seeing these patients, we're taking into account that fluid burden, and looking at their current weight and assessing how much fluid we think they're carrying, so estimating a dry weight. There is guidance out there in the guidelines as to how you can estimate dry weights, but also you can use things like their pre and post paracentesis weight to guide that, and patients are generally pretty good at being able to tell you what sort of their normal weight is and how they feel that's fluctuating. So looking at Lisa's estimated dry weight, she's coming out at BMI of roughly 19, and this is showing that she has clinically significant weight loss of around 15%. Next slide. So again, really helpful sort of quick reference guidelines that you can access if you're not necessarily familiar with doing sort of a full nutrition assessment with your patient, but just to kind of give you some headlines. It's looking at where they're at in terms of their decompensation, how advanced their liver disease is, putting into context their BMI, so are they currently classified as underweight, normal weight, or high BMI. And then that can give you a bit of a guide as to whether they may be high risk of protein energy malnutrition or sarcopenia or frailty. And then it can give you a little bit of a guide as to where to steer that patient. So can that patient be managed and just monitored at the moment, or do they need referral to a dietitian, or do they need perhaps more of an urgent inpatient admission for a full assessment, and potentially some more advanced nutrition support? Next slide. And hopefully you'll all be familiar with these new malnutrition screening tools. So MUST is a really common generic malnutrition screening tool that is used in hospitals, and it should be completed for every patient. But unfortunately, this isn't cirrhosis specific, so it doesn't encourage those completing this to consider any change or fluctuation in their weight due to whether it's a cystic volume or edema presence. So there is a validated tool for patients with cirrhosis, the Royal Free Hospital Nutritional Prioritizing Tool. And this is really good in terms of encouraging you to really think about the fluid overload with this patient. It has a higher level of accuracy in terms of understanding or screening that patient for a risk of malnutrition. So it can't diagnose malnutrition, but what it can do is give you a guide as to, again, where that patient's at, and the priority of moving forward with some more specific treatment for them in terms of their malnutrition. And again, so for Lisa, so similarly for George, we've taken a food history. So she's reporting early satiety, and that's particularly gets worse as her acidic volume reaccumulates. She's also avoiding a lot of foods, and she's reporting a very low appetite. So it's understanding that a little bit more with Lisa, and we will come on to why she may be avoiding certain foods. Again, looking at her body skeletal muscle, this is coming out around the 25th percentile for her sex specific reference values. And again, she's always been quite slight, she reports, so this is probably fairly normal for her. So she's actually seems to have done pretty well at maintaining her muscle mass. Often we find with females, and particularly with the background of alcohol-related liver disease, tend to be much better at maintaining their muscle mass, but often waste their fat mass. So likely some of that weight loss Lisa has had has come from muscle, but there'll also be quite significant loss of general calories, so general fat mass as well. Again, similar with George, her hand grip strength is showing significant depletion. So that's coming out at only around 40% of the gender-specific norm for Lisa, where she should be. So that's again showing that evidence of protein energy malnutrition and sarcopenia. And next slide. But again, when we look at in a little bit more detail, so when we actually assess Lisa's physical frailty, she's come out as frail on the liver frailty index. And again, it's just important to look at that snapshot with Lisa. So she really struggled to do the chair stands. And again, she a lot of that was because of the acidic volume burden. You might get a different score on a different day, particularly if these patients are, 1 or 2 days recovered from a drain. So it is important to review these, monitor, and not just take one snapshot. But when we've looked at Lisa's Darcy index, she scored much better than George. So she scored 25 points with METs of nearly 6. So actually, while she sounds on paper sort of more sarcopenic, more frail, she's actually functioning much better. So she is actually motivated to keep moving. She's still doing housework, she's still doing her shopping, and she's still managing all of her daily living care. So again, this is why for us to sort of highlight the importance of not just taking one snapshot measure. There are really simple tools that we can look at to assess these patients more holistically, and it's important that we're doing so to get a full picture of these patients. Next slide.
Yeah, so if we go back to the kind of concept of whole person optimization, again, I can't speak loudly enough to start the rifaximin earlier rather than later. We used to rely on the fact you needed 2 admissions to hospital optimized on lactulose before starting rifaximin, but we know that rifaximin can interact with muscle to help with the absorption of ammonia, and if your liver is already kaput, it's your muscle we're going to rely on to be able to absorb that ammonia. Again, her polypharmacy, we've got a question mark whether the lactulose is actually making her dehydrated and contributing to her fear of foods and diarrhea, therefore might be more negative than positive. The propranolol, we've really got to think about whether that's contributing to her low blood pressure and whether it's going to limit us exercising her and getting that balance right with regards to risk of varices. Again, stopping smoking, alcohol abstinence is going to help her protein muscle synthesis. And also giving her clear goals. I always find it frustrating when a patient can't get into ambulatory paracentesis on a regular basis and they're waiting 3 weeks with 10 litres of fluid on their abdomen. You're just going to lose ground massively no matter what you try and do.
Just to touch on some other interventions that we could implement with a patient like Lisa. So I mentioned that she's deselecting certain foods and she's lost a significant amount of weight. And often there's a high burden of pancreatic exocrine insufficiency with patients with an alcohol background. And this is what Lisa is presenting with. So she's reporting symptoms of steatorrhea. And it is important that we're asking these questions. We're making sure we're checking not only that they're opening their bowels regularly, because we want to make sure from an encephalopathy point of view, we want to make sure we're understanding, is she displaying any symptoms of malabsorption? So for Lisa, we would be looking at a trial of pancreatic exocrine replacement therapy. So our first line would be Creon, and we'd be making sure she's educated well and knowing when to take that. So with all of her meals, with all of her snacks, all of her milky drinks, and also that she's confident that she knows how to titrate those doses as well, so that she can make sure we can really optimize that absorption quickly. And then again, just looking at what we would implement from a nutrition point of view for Lisa. So similarly to George, we would be looking at optimizing that protein quality, but we also need to recover some of Lisa's weight. But just to be more specific for Lisa, she was presenting with jaundice, and we've also identified exocrine insufficiency. So we want to make sure we're not giving her a really high fat load, particularly with the supplements that we'll be recommending. So there are not as many options in terms of low fat, high protein supplements on the market, but there are a number that we would use as our first line. So we want to make sure that we're giving good carbohydrate, good protein, and keeping the volume small. However, we did do a little trial with Lisa. We gave her a little bit of time on oral nutritional supplements, but felt actually because of the acidic burden, the fluctuating encephalopathy, and just how low her sort of function or strength was in terms of the hand grip and the frailty measures that we were still getting, we decided that our best treatment course for Lisa would be looking at enteral feeding. So we initiated nasogastric feeding, and actually there's really good evidence for management of acidic volume, in particular when we implement early sort of enteral feeding, whether that's a nasogastric or nasovaginal, depending on what the patient needs. And this can really ensure that you're accelerating their nutritional input. You can often patients do well with a night feed, because then they can continue to eat and drink bits and take the oral supplements in the day, and you're just really making sure you're maximizing their chance of getting good nutrition and are meeting their targets quickly. But again, we want to make sure we're choosing the right feed for this patient. So we're keeping it low fat. And it's also good to choose a feed that has a high MCT proportion, so medium chain triglycerides. Because of the jaundice level, we want to make sure that we're optimizing that fat digestion as best as we can as well.
Brill, thank you, Jenny. So in the last 5 minutes, we're just going to go on to exercise and the benefits of. I mean, there's no doubt from a brain point of view, mood, liver, bone, muscle, adipose, heart, lung, there's multiple advantages of regular exercising. But the big question is the government guidelines of at least doing 150 minutes of moderate intensity exercise a week, or replacing that with vigorous intensity for half the amount, together with balanced techniques, resistant exercise. Is that realistic in our patient cohort? Well, currently in the population, 20 million of us don't do it anyway, and we haven't got the excuse of having cirrhosis or decompensated liver disease. When Felicity looked back, and she basically got a good cohort of at least 50 patients to wear the wearable watches, which the patients were blind to, so it gave the patient no positive feedback, but it gave us data on how sedentary they were. And if you look at the graph on the left-hand side, this is for moderate to vigorous physical activity, minutes a day. And as you can see, compared to a healthy control cohort, who I would argue aren't that healthy, only doing 100 minutes a day, the end-stage liver disease patients were averaging about 25 minutes. But even more so, what the watches can tell you with some very intricate analysis that Felicity's done is if we look at the dart board on the right, the further you are out to the peripheries of the dartboard, the more intense the exercise. So around the outside of the board is roughly indicative of a slow run, and the inside is more a slow walk. And as you can see from the end-stage liver disease patients, they're barely getting to a point where they're doing a brisk walk, never mind a slow run, and that's for about 30 minutes a day, if that. And then when we break the cirrhosis patients down into frailty scores, again, with a low frailty score being the most robust and the purple being the high frailty score, the most frail, the most physically frail patients were just about managing a slow walk for 1 minute a day. And that's 1 minute a day. So they're basically walking to the toilet and back from the couch, and that's about what they're managing. So setting them a target of 150 minutes of moderate physical activity is not going to be achievable. Our main excuses, if we think about people on the Zoom call today, is we're scared of hurting ourselves. You know, we might blame the weather, like when I woke up today and it was snowing, I wasn't that keen on putting my shorts on. Also, we've got kids and you've got to drop them off at school, so we're more likely to drive than walk or cycle to work. But then there's also motivation, depression, low mood, and other things that are stopping us doing exercise. But with these kind of patients, and especially the latter patient we've discussed, she's got pain, she's anemic, she's got protein malnutrition, fatigue, sarcopenia, she's socially factors, she's a long distance from any kind of gym or anything that she can do with regards to carers. But the biggest hurdle for her is healthcare professionals and the lack of expertise that we have and access. The big question we always get asked is exercise safe if you've got portal hypertension? So previously they said no, but what this very eloquent study showed from Barcelona is that if you optimize the patient with beta blockers first, which is the black line, you can actually reduce their pressure gradient with exercise on top of the beta blockade. In addition, the same group a few years later developed an intensive lifestyle intervention to look at what that did to portal hypertension. And what we do know is that if you're losing approximately 10% of your body weight, we're seeing much greater reductions in your portal pressures as measured by the right jugular vein of up to 23% decrease. So I would argue as long as you've got optimization of the varices or you've got them on a beta blocker, crack on with the exercise. I just wanted to highlight to you that the timing of exercise is quite important. And I mean, we're approaching 8 o'clock in the evening, which means that our blood pressure is pretty high, our body temperature is getting ready for bed, and our melatonin wants us not to be on a computer screen. But if you're going to exercise, really your coordination, your reaction time, and your muscle strength is best in the afternoon. When we look at all the published literature of comparing supervised hospital-based therapy versus home-based therapy, they share that they can both increase muscle mass, functional capacity, quality of life. There's been no reported complications of variceal bleed or portal hypertension. But sadly, they're all small in sample size. They're majority about aerobic exercise like walking, running, swimming, and they all concentrate on compensated cirrhosis, not decompensated. I mean, the advantage of a hospital-based approach is there's better adherence because you're right in front of the person delivering the exercise. But then there's the huge limitations of travel, patient costs, limited capacity and time commitment. And again, home-based is low cost. We've proved it's flexible and we've proved it's feasible, but the adherence is questionable. So Felicity and the team, together with some of the anaesthetists and ourselves, developed a home-based exercise plan, crikey, about 5 to 6 years ago now, with some basic exercises of mini squats, mini press-ups, crawling on the floor, trying to build that patient's confidence. And what this showed in a group of 55-year-olds in a small study, that even when we withdrew the telephone support on a weekly basis to guide their exercises, there was still good compliance throughout. And we showed throughout that we could improve their muscle strength, their quality of life, and their short battery test, which is kind of a measure of frailty. But what the feedback from the patients did say is that nothing was being done to address their motivation, their mood, and how determined they were to complete the tasks. So as a result, we were very fortunate to get funded for a proper randomized control trial. And the reason this is so important is this includes something called the self-determination theory, whereby we're empowering the physios to do the job of a psychologist, where they're getting specific behavioral techniques of how to apply their exercise to the patients, both pre and post-transplant, compared to just giving them a leaflet in the controlled arm. And the main primary outcome, as driven by the patients, is quality of life. And hopefully this time next year, the likes of Jenny, myself, and Felicity will be able to give you the results of the study. What we are doing, though, we're trying to figure out how do we determine at what level of resistant exercise they go in. You can't just say to everyone, right, off you go, do a plank for a minute. So we're using the liver frailty index to determine what kind of exercises they should be doing from their baseline. And depending on what the liver frailty index does, we can then up the amount of exercise they're doing and the frequency. Alongside this, we can use the Darcy index to determine at what level of difficulty their aerobic exercise can be. And this can be anything from very slow walking, cycling, kickboxing, etc., alongside the physiotherapist. So overall, to summarize, and I think we're just about on time, physical frailty predicts mortality. Please optimize safe drugs first, like Creon and rifaximin, but these patients must hit their protein targets. Just coming across to us on a 40-sip juice is not going to touch these patients at all. If you are going to set up exercise programs, they need to be individualized to the patient based on their LFI and their Darcy. And I would argue, in the absence of doing multiple CTs and CPETs, which are very expensive and need expertise, use the LFI and the Darcy to see if these patients are improving. What does the future hold, though? We still don't really know the frequency, intensity, the type, or the timing of exercise we should be doing, but Exalt should help with that. What motivational techniques should be using? These poor patients sleep for 2 or 3 hours a day, so how do we tackle sleep problems? But also using newer technology of virtual and remote monitoring rather than dragging them to hospital to see whether they're responding to therapy. But we've got to appreciate there is always going to be a group of non-responders who are just too sick. And I don't think we should specify, like Jenny alluded to, LFI targets that's a yay or a nay. It more should be to do with engagement and whether they're improving. And then really there's a huge barrier of research that needs to be done on new weight loss drugs in these very severely unwell patients. And I'm going to stop sharing now and hopefully
Matt and Jenny for such an amazing
allow the room to
talk
start asking
on
some questions.
Wow, thank you very much. This topic of frailty in cirrhosis. So for anyone listening, please feel free to post your questions in the chat, and we will get through as many of them as possible. Maybe if I could start with a question, Matt and Jenny. So you mentioned that in the work they've done previously and published, females are more prone to sort of physical frailty compared to males. So can I ask why, and should they therefore have different forms of prehab compared to men?
Yeah, so that's a really good question that we don't fully understand. And I think one disadvantage the females have in the published literature is a lot of it is based on muscle mass. And females in general, I don't want to speak out of turn, but liver female patients in general have a smaller muscle mass, but as Jenny alluded to, a better function. But very much so, it should be tailored to the gender and the individual, which Jenny can allude to. But we shouldn't be setting the same parameters. It's a bit like MELD and UKELD. the Americans have a huge problem because women have a lower creatinine because they have lower muscle mass, which meant historically their MELD score's lower. So they realized in America that women were being disadvantaged on their transplant waiting list, and they've now adapted the MELD score for gender. But it's a really good question.
Great, thanks. Can I just echo what Hal said, that was such an interesting talk. We've got a couple of questions coming through, but can I just really jump in with my own one first? I'm a bit jealous that you get to have Jenny in clinic with you, Matt. That's the first thing I wanted to say. So if we could all have a Jenny, that would really help our patients, I think. But sometimes it can be a little bit overwhelming, isn't it, when you're faced with this person that doesn't eat properly and does no exercise and is really frail. If we and it can be overwhelming for the patients as well. So can you tell us what, like, top 3 tips or something that you would say to them, top 3 most important things or something, so it's not too overwhelming for all of them for them in one go?
Yeah, I'll leave this one to Jenny, I think.
Personally, I always kind of just, it really doesn't take too long just to get a really quick understanding of what that patient, what takes a patient in a day. So how are they spending their day? And then I would focus on just a couple of things from that day. So often we find the common things coming through are patients aren't able to eat regularly enough. It becomes a really emotional thing around meal times. Particularly if they're not sleeping well, they're eating at different times, they're unmotivated. So I would really take from the patient what is going to motivate them most, or what is disadvantaging them most. But if you want to really keep it simple, make sure they're eating regularly, so they're not having long fasting periods. That's really key. Don't just focus on protein. We always talk about protein, and patients always say to me, you're going to talk to me about protein, but protein is so important, but actually you want to make sure they are getting regular carbohydrate in. I've seen quite a lot of patients recently who have been really scared to take carbohydrate because they've been told protein, that actually they've not got that quick accessible fuel. So that all that protein they're taking isn't actually doing what they want it to do, and they become demotivated because they're not seeing improvements. So regular eating, combination of carbohydrate and protein, and then whatever's going to motivate them the most. So I always use, if they're having regular drains and that's bothering them, I would use that as a motivated target to say, if you improve your movement, if you improve your nutrition, we can actually reduce the drains, for example. So I would pick what's going to motivate them the most as their sort of targets go away with.
Great, thank you.
We've got a few questions from the chat, if that's okay. So first question is, if you measure spine L3 in practice at all from CT, and if so, are there any specific software best to use for that?
Yeah, good question. So yeah, I must admit, outside the research capacity, we don't necessarily have a CT report telling us the L3 SMI. There is software around the corner. We are about to try and validate the software in both Exalt and a collection of 300 patients we've got CTs on. But I must admit, trying to get the software approved by procurement in an NHS situation is a freaking nightmare. So I think it's coming. I would hope in 5 years' time, most radiologists will give you either a low, moderate or high sarcopenia score, keeping it nice and simple. So you've got a muscle mass score alongside your function in clinic.
Thank you. So we've got another question coming through. So as part of prehab, should the hepatologist or gastroenterologist be prescribing the antidepressants, or should we rely on the community to do this? And any particular antidepressant? And me butting in there as well, I'd also be really interested in your thoughts on whether we should use a bit more mirtazapine because of, as you said, the increased appetite with it. And they also then said, thank you for the excellent talk.
Yeah, I've got to be careful how I answer this one because my wife's a GP. In short, I'm a bit biased when I'm running the waiting list clinic. I do prescribe antidepressants, and I think if you're referring someone to a transplant centre or you're concerned about their mood and motivation, it depends on, I first say to them is, do you trust your GP? Have you got a good relationship with your GP? Have you got access? If they say, no, it's a nightmare, I can never get in, then I would just prescribe it myself. But I would prefer the GP to do it because they're just better at it and they're better at monitoring those symptoms. But again, I would take SSRIs are safe. So in someone like George, who's overweight, got sarcopenia obesity, go for something like sertraline. But in the knowledge that you need to start low, it might make him more anxious before he gets better. But then in in the other patient, Lisa, as Louise has alluded to, we'd more favour mirtazapine because it might increase her appetite and help her gain weight. But just be knowledgeable that mirtazapine is a lot more potent. It's one of the strongest antidepressants there is. So start small at 15 and be very, very slow to wean it up.
Okay, great, thank you. If anyone's got any other questions, if they want to put them in the chat, that will be great. Otherwise, I've got another question for you, if that's okay. So, slightly random, but on the start of exercise, should we be encouraging our patients to get watches, the smart watches, to monitor their steps? Is there any evidence that that helps or doesn't help? Or what do you, or tell them to just avoid it totally because it's...
I mean, the one thing to say is when we got the watches for the trial, the first thing to say is every single watch gave them a rash because the patients are so scared of taking them off and cocking up our data that they didn't take it off for showers, they sweated in them and they got awful rashes. So I think it depends on the individual. If you've got an individual who likes objectivity and positive feedback, then a step count monitor could be useful. If they're going to look at it, get depressed because I've only done 500 steps because I've had a really bad encephalopathy, that could be very negative as well. I think the vogue will be that people may wear watches, but it will give the hospital data, but not feedback to the patient. But that would need obviously consent and very careful ethics doing so.
We have another question from the chat. Brilliant session, thank you. Would you mind just covering the use of dapagliflozin in cirrhosis again, please? I have quite a lot of mastoid cirrhosis patients with heart failure with preserved ejection fraction or CKD that also have poorly controlled diabetes. Would DAPA still be okay in these settings?
There's some good questions today. Yeah. So if they're compensated, I'd say yes, but make sure that patient is counselled that if they become unwell, if they're not eating or drinking, or someone's lining them up for hopefully some kind of operation, God forbid, even if they're having a line put in for dialysis, they've got to stop the dapagliflozin, because if they have it on a fasted state and they're still peeing out glucose, you're setting them up for a very bad ketoacidosis. As soon as they show subtle signs like their albumin's dropping, their ionized drifting of decompensation, it's got to be stopped. And you've got to have a low threshold then to go to insulin. Obviously, as a transplant centre, we're not going to be that interested in them if they've got heart failure. But you're right, if they've got proteinuria, an ejection fraction of 45% and very compensated, SGL2s have got good evidence for all three of them.
Great, thank you. So we've got another question coming in, and this one says, who usually assesses the DARSI scores that you're talking about in your clinic? Do dietitians, the anaesthetist, or somebody else, or yourself, Matt?
Well, I'm going to let Jenny answer this, but then I'm going to, I got shouted at the other day, and then I'll give my answer.
I think I know what you got shouted at about. Yeah, so I routinely, if our patients have access to a physio, we would leave it to them. I do complete it in part of transplant assessment if there isn't a physiotherapist available. Our anaesthetist will do it as well, but we want to make sure that if it's going to be whoever it's completed by understands how to interpret it and also is using the actual form, because often we do sometimes find you know, it's not good to just sort of ask those routine questions and kind of, you know, average a score, which sometimes we do find happens. We can get conflicting DARSI scores. So I would say, you know, physio, dietitian, medic, whoever is best placed, going to be seeing that patient regularly enough and can understand the interpretation of it, but make sure you are actually using the form and calculating it accurately for that patient.
Yeah, so I mean, we're a bit like the Man City football bench. We're a bit spoilt in Birmingham in the fact that in one clinic you'll have a dietitian doing it, you'll have the anaesthetist doing it in the waiting assessment, and then you'll have a physio doing it in a separate room. And surprise, surprise, they all give you a different answer. So if you've got the luxury of having a Felicity, then fantastic, because she understands the Mets equivalent of every question that she's answering. I certainly don't. But that said, if I was stuck out in Hereford or Wrexham in the real world, you know, if a referring clinician has had a crack at this and is sending us the Darcy index, brilliant. You know, because we are still going to use that to determine whether in the future we put them straight into a prehab clinic and assess them through that first, or whether they're actually quite robust and they can go straight to a transplant assessment. So it would be great if referrers start doing it alongside an LFI, because then we can prioritize who needs to see Jenny and Felicity rather than me, basically.
Can I ask one last question before we close? What do you think there's a role for doing these frailty assessment in the pre-cirrhotic population, so i.e. to prevent decompensation in hospital admissions? Because obviously all the work that you guys have presented are all in cirrhotic patients and or compensated then decompensated. So I guess the question is, do you think there's a role in the pre-cirrhotic population or not?
Yeah, good question. I mean, in the title you made us talk about cirrhosis, but with your Mazdod hat on, you know, you could argue starting to do it in F3s in sarcopenic obesity would be very good, you know, because you can introduce them to a Jenny earlier rather than later. It hasn't really been validated outside of a non-cirrhotic population, is the first thing to say. The other thing to say is if you take a PSC group, for instance, you know, they tend to be young, active, and a lot of them are actually quite physically fit. So that's why I think it's important to use a continuous score like LFI and Darcy rather than something like a short performance battery test, which is categorical, because most PSC, young PSC patients will all score maximum score. But yeah, that would be a great project to do, just rolling it out to general hepatology clinic and map out the bell shape of frailty, because I have no doubt in a Mazdod clinic in particular, it won't look that attractive.
Great, thank you. Sorry, I had a slight computer freeze for a second. So we're coming up to 8 o'clock, so I'm going to have to close the webinar. So thank you again to Professor Matt Armstrong and Jenny Towie for that excellent session. We really appreciate your time and you sharing your knowledge and expertise with us. And thank you to everyone who participated and for the questions. Before we go, I hope that we can just very quickly mention our online Basel Extra meeting, which is coming up in the end of April and the start of May. So this is a multi-professional topic focused education event. We have 3 sessions running on 3 consecutive days. The first one on immune mediated liver disease, the second session on optimizing health in people with decompensated cirrhosis, and our third session is complex cases. So it'd be really great if people could look at the Basel website and think about registering for that. That would be super. Thank you. So thank you again to my co-chair and to Matt and Jenny for everyone for joining us this evening. Thank you.